So good afternoon, everyone, and this is a session which is sponsored by Astellas. I'll be speaking about Enfortumab Vedotin in relapsed refractory bladder cancer. So we know that bladder urothelial carcinoma is a very aggressive cancer, and it is a cancer which has a large unmet needs, especially in our setting. And chemotherapy alone has not has limitations, because after chemotherapy multiple patients progress and we still have this unmet need in improving survivals. Right now, with the advent of immune checkpoint inhibitors, the antibody drug conjugates and erdafitinib, outcomes are improving, and today I'll be discussing on Enfortumab Vedotin. So we know that up to 50% of the urothelial cancers that we see are unfit for first-line cisplatin-based chemotherapy. Many of them may not respond to it, and we also have a significant number that do progress on immune checkpoint inhibitors. Survival has still not reached its dismal at 5 years, which is less than 5%. So Enfortumab Vedotin is an antibody drug conjugate, which was first evaluated in the setting of failure on standard chemotherapy cisplatin-based doublet, along with the second line or a prior immunotherapy with a PD-1 or PD-L1 inhibitor. This is the first study which evaluated this drug, and we know now that it has been even tested in the first line setting in combination with pembrolizumab. So this is going to focus only on the second line and beyond treatment, that is in patients who were previously treated. Just to understand the patient population that was included, it was either locally advanced unresectable or metastatic urothelial carcinoma who had progressed on an immune checkpoint inhibitor, either a PD-1 or an anti-PD-L1, and who had also failed a platinum-based containing chemotherapy. It could have been either in the metastatic setting or in the neoadjuvant or adjuvant setting. If the patient had received neoadjuvant platinum-based doublet or adjuvant platinum-based doublet, the patient had to have disease progression within 12 months. So again, once you progress on these first two lines of therapy, that subgroup of patients had poor outcomes. And at the second or third line setting, many patients are going to be unfit for further systemic therapy. So this was a phase 3 trial which compared Enfortumab Vedotin with chemotherapy. A word about Enfortumab Vedotin: it's an antibody drug conjugate. Just to understand that there is an antibody which is targeting Nectin-4, which is expressed on most of the urothelial carcinoma cells. And this monoclonal antibody will target the Nectin-4, and it has a chemotherapy component which is monomethyl aristostatin E, which is kind of a microtubule inhibitor known as MMAE, which is conjugated to this antibody, and this allows the release of the chemotherapy agent specifically to the cells expressing nectin. So it's more specific, and it's supposed to minimize toxicities. So this is the study design, like I already mentioned. It is in the patients who have progressed on first line and second line treatment, platinum-based therapy and immune checkpoint inhibitors. They were randomized to either investigator choice chemotherapy, which was the standard of care at the time, or to Enfortumab, which was the study drug, which was given IV. It was 1.25 milligrams per kg, and it is given every week for 3 doses in a 28-day cycle. Overall survival was the primary endpoint, and the first interim analysis was done after 65% of patients had died, and the final was supposed to occur at the time of 439 deaths. So if you look at this study, these are both the arms. They're well balanced. Median age was around 68 in both arms. A significant number of patients were older than 75 years, which is expected with urothelial cancers. A large number of patients were male, more than 75% in each arm, and around 55% in both arms were patients from Western Europe and the United States. And of course, this is the smoking smoking history of patients and the diabetes history. Knowing whether the patient had hyperglycemia and diabetes is important, because specifically the toxicity of EV is hyperglycemia and complications related to uncontrolled sugars. Again, these are the subgroups which they eventually did a subgroup analysis for. So they looked at ECOG PS, around 60% had a PS1, the risk scores, the sites of origin. So 2/3 were bladder, about 1/3 were upper tract, and whether it was transitional or urothelial carcinoma versus mixed and other histologies, and what are the sites of METs, and also prior lines of treatment. So most patients received 1 or 2 prior lines. Small proportion, around 12 to 13%, were more than 3 prior lines of treatment. So in this group of patients which has failed first and second line therapy, Enfortumab improved survival over chemotherapy. The chemotherapy was either docetaxel, which was given 75 milligrams every 3 weeks, or paclitaxel, or vinflunin. And compared to chemo, there was an improvement in median OS, which was 12.9 months approximately versus 8.9 in the chemotherapy arm, with a hazard ratio of 0.7. And at 1 year, there was almost 11% absolute improvement in overall survival, with Enfortumab Vedotin having a survival rate of 51.5%, and the control physician choice chemotherapy, which was around 39%. So because there was an improvement in survival at the interim analysis, the study was prematurely closed for the benefit. And now let's look at the subgroup analysis. So these were the pre-specified groups which I had shown during the baseline characteristics. So Enfortumab seemed to have better outcomes in almost all groups, whether it's age, whether it's the presence of liver mets, patient who has received prior checkpoint inhibitors, and depending on the group of chemotherapy, which particular chemotherapy drug was used. It didn't seem to make a difference. Of course, patients who are younger, because of better tolerance, had a slight advantage, where you can see the age group over 75 years cross the line of unity. So those are the patients which may not benefit because of the toxicity profile. Again, this is the progression-free survival. The median was 5.5 months compared to 3.7 months with chemotherapy. And you can see there is a significant tail here, whereas almost all patients with chemotherapy have progressed before 20 months. So this is again the progression-free survival analysis, which again showed that in most of the subgroup specified, whether it is the site of the tumor, upper tract versus bladder, liver mets, prior systemic therapy, and age, there has been a benefit with the use of Enfortumab Vedotin. Response rates were significantly better, almost double with Enfortumab. So this pie shows you the number of patients who responded, which include complete responders and partial responders, and it was 41%. Whereas with standard chemotherapy, that is docetaxel or vinflunin, it was around 18.6%, with only 3.4% having a complete response. Again, this is a similar kind of subgroup analysis forest plot for response rates. This is the decline or the improvement in the responses, that is shrinkage, the absolute difference from baseline to the assessment. And in all subsets here, except the older patients above 75, responses also were better with the use of EV compared to the physician's choice chemotherapy. Quality of life seemed to be maintained. The dips here you can see below 10 is considered a clinically significant change in the quality of life. So you expect someone who has a drop of more than 10 points to have a worsening of quality of life. And the dips with EV seem to be less, so relatively maintained quality of life as compared to chemotherapy. So just to summarize, this was the quality of life data. During the first 12 weeks of treatment, when they used the EORTC QLC30, the global health status, which is the overall quality of life assessment in that questionnaire, was maintained, and it was more stable as compared to the dips with chemotherapy. Pain was significantly reduced when you looked at chemotherapy at week 12, that is at 3 months. But again, loss of appetite was a concern with Enfortumab Vedotin. Patients who had EV had almost all the functioning domains, and many of the symptom domains had an improvement. So the only caveat is this was an open label study, so patients were aware whether they were receiving EV, so that may have influenced partially the quality of life assessment. But what is important to know with Enfortumab and chemotherapy in second line and beyond in urothelial carcinoma and advanced disease is the side effect profile. Enfortumab has a specific class of toxicities which are important to understand. One which is predominant is peripheral sensory neuropathy, skin toxicities, keratitis, and fatigue and loss of appetite. Now, some of the toxicities are related to the targeting of nectin on skin and other tissues. Hyperglycemia and neuropathy is not completely explained, the exact mechanisms, but we have to be aware. So, as compared to chemotherapy, the any grade incidence of peripheral neuropathy and grade 3 marginally was increased, but peripheral neuropathy, all grades was significantly increased with the use of EV. Pruritus was significantly higher, though the rate of grade 3 or higher was negligible. Taste abnormalities and rash, which was also significantly more in the EV arm rather than the physician choice chemo arm. But like we all know, chemotherapy has its predominant effects on the bone marrow, so myelosuppression was significantly higher in the patients receiving chemotherapy. So these are some of the adverse events that led to death or which had, and if you look at the events excluding disease progression, it was a smaller number, that's 3.7% and 3.8% in each arm, which was comparable. And correlating with the toxicity profile, hyperglycemia, abscess, pneumonia, shock were the cause of death in the EV arm, and neutropenia, sepsis, and pancytopenia was what was expected, and it were the causes of death in this small group of patients in the chemotherapy arm. And again, the same causes which caused dose reduction, sensory neuropathy, rash, fatigue, and decreased appetite for Enfortumab Vedotin, and also dose interruptions. So most of these adverse events were mild to moderate severity, which I pointed out in the previous slide. The incidence of grade 4 skin rash is quite low, 1 patient each. Grade 3 around 14%. Ocular disorders, grade 3, just 2 patients in the entire trial population. And some patients had serious infusion reactions, which is 4 patients here. Most of them were grade 1 or 2. So just to summarize, the use of Enfortumab in second line and beyond in urothelial carcinoma in the advanced setting decreased the risk of death by 30% and the risk of progression by 37%, had nearly double the response rates with a higher complete response rate, and also significantly improved the pain score and the quality of life in the pain domain. So this was a phase 3 study in summary, which compared standard chemotherapy, that is physician's choice, to EV in patients who were pre-treated with platinum chemotherapy and an immune checkpoint inhibitor, and it was effective and improved overall survival. So let's look at the real world data for use of Enfortumab Vedotin. We know that we discussed about access in the previous panel, and we know that access may be limited, but there is some real world data which is across US, Europe, where they have used it. And it seems to be that the data which is available, and this is a paper published in 2022, which looked at registry data. So they had an objective response rate of 52%, which was comparable to the 41.3% in the trial setting, a progression-free survival that was slightly higher than the 5.5 months in the trial setting, and an OS which was slightly higher than the 12.8 months in the trial setting. And again, they showed that both the urothelial and the variant histologies had pretty good response rates. So this is what they highlighted, which correlated with the trial data. They also looked at patients with risk factors such as neuropathy, no neuropathy, diabetes, and FGFR mutations. It seems that this drug in the real world setting has response rates in even the adverse prognostic factors, such as variant histologies, liver metastasis, and in patients with FGFR wild type versus altered, it seemed to be almost the same. So this was the patient population that was included in that registry, and I already discussed the survival outcomes. What they showed is that whether there was patients with multiple lines of treatment or just 2 prior lines of treatment, whether they had variant or urothelial, pure urothelial histology, or whether they had liver mets or no liver mets, their response rates were consistently better with Enfortumab. But the caveat is that though they had better responses in patients with liver mets with Enfortumab, the overall survival in general, even in this real world data, was inferior for liver mets. This is the same slide which they showed the response rates across various variant histologies. And they also looked at what is the component of the variant histology, if it was less than 50% versus more than 50%. And across the board, if you look at the slide, you see that the higher the proportion of variant histologies, they had poorer response rates, whereas the UC predominant histologies had better response rates. So again, though they have good responses in variant histologies, the pure urothelial histology still does better even when Enfortumab is given. This is some similar data from the European database where again it shows comparable progression-free survival to what was shown in the trial and a 12-month OS, which is similar to the trial setting. Toxicity is also similar to what was experienced in the trial, and this was their median overall survival, 12 months, and a median PFS of 7 months. Japanese data also, which had 5 centers in Japan, small data with 9 patients, again similar to the trial setting, clinical response in 43%. What they interestingly showed in this small patient population is those that developed peripheral neuropathy had better outcomes in terms of PFS and OS in the Japanese real world data. So it seems like from the data from North America, Europe, and Japan that the efficacy which is seen in the real world and the toxicity profile matches that of the trial setting, and it is reasonable, and it is not, there's no discrepancy in this subgroup with the use of Enfortumab Vedotin. So with this, I'll conclude my talk, and thank you for the patient listening.